Okay, we're going to cover the Luzerne County Community College 203 Heart Failure PowerPoint. And I'm doing this for my benefit, but if my classmates want to, feel free and look on. If they're having a hard time, that's what we're here for, to help each other. Anyway, this PowerPoint's on heart failure. We're going to talk about cardiohemodynamics. Cardiohemodynamics, basically, we're talking about cardiac output. As you know, cardiac output is measured by heart rate times stroke volume. And stroke volume has three components, and it's preload, afterload, and contractility. Preload, as we have studied, is the amount of blood in the ventricles at end diastole, and afterload is the amount of resistance that those ventricles are going to meet when they're pushing out into your body, predominantly the aorta. That's how much force it's going to need to contract. And then your contractility is basically the heart's ability to forcefully eject blood both into systemic circulation and pulmonic circulation. So in class we talked about Frank Sterling's law, which says, in a nutshell, that to some extent the force of the stretch of the muscle, sarcomeres, that as that stretches, the stronger the force of the contraction. Or another way to look at it is that as much as that muscle stretches, the smaller, the more narrowing of that muscle up until it can't stretch anymore, pretty much. So we talk about heart failure. Heart failure. Our goals in our treatments are to do three things. We want to decrease the workload through rest. We want to increase the contractility through medications like positive inotropic drugs like digoxin or PDE inhibitors, and then we want to also decrease excess fluids, and by doing that we're going to use things like diuretics. Okay? So our meds, specifically for all three components of the stroke volume, our preload, afterload, and our contractility, we're going to do nitrates for preload, diuretics. We're going to try and maintain low sodium diets. That's usually your answer for everything that's related to cardio. And also the best position for the patient who has issues with preload is a high Fowler's position. For afterload, we're also going to do nitrates, we're also going to do diuretics, we're also going to do sodium, decrease in sodium in your diet, but then we're also going to add the ACE inhibitors as well, and the vasopressors. Just a touch, as Mr. Honeywell said. Contractility drugs, we're going to use positive inotropic drugs, and those are the drugs we talked about, being your glycosides, such as your digoxin, your PDA inhibitors, and your catecholamines too, such as dobutamine and dopamine. So now we're going to go into our goals. What is our goal for our treatments? Even though these are our treatments, these are our goals. We want to diagnose early. We want to promptly treat so that we can minimize complications associated with heart failure. But then we also want to prevent remodeling. Remodeling is crazy because what happens is that the heart is going to start changing as a result of ventricular hypertrophy. The muscles are working so much that eventually they poop out, and as a result, that muscle will no longer be the same. It's been remodeled. So that's what we're trying to prevent in heart failure, that remodeling. So the signs and symptoms of right-sided failure and left-sided heart failure. The key component here is to remember that left-sided heart failure causes right-sided heart failure. So we're going to take a look. Right-sided heart failure, we're going to have weight gain. That fluid is no longer circulating, it's going to start pooling. Gravity pools, right? So you're going to have weight gain, and as a result, you're going to have that peripheral edema, ascites, and anasarca. All of these issues have to do with fluid imbalances. Your jugular vein distension, very common classic right-sided heart failure problem. You're going to have engorged livers, hepatomegaly. You're going to have anorexia, fullness, nausea, and fatigue. Fatigue is very important. Then you have left-sided heart failure. You're going to have those issues associated with the fluid backing up back into the lungs, obviously. You're going to have non-productive cough. Specifically, you'll see it in crackles, or as Mr. Honeywell said, they call that rails, old school. You'll have dyspnea, orthopnea, hemoptysis, which is that sputum, that blood in the sputum. You'll have tachycardia, specifically S3, S4. You're going to have activity intolerance, fatigue, and your skin is going to be cool and pale. But as a result, with the left-sided, everything backs up and eventually it's going to go right into right-sided heart failure, which is why the theory is based on left-sided heart failure will lead to right-sided heart failure. So we're going to move along. Some points that he talked about with regard to preload imbalances, whether you're increased preload or decreased preload. If your preload is increased, you're going to be dehydrated. So typically what they'll do is they'll treat the patient with 1 to 2 liters of normal saline. You'll have, when the preload is decreased, then you're just going to do the opposite. You're going to have overabundance of fluid, so as a result you're going to treat it with something like diuretics. Diuretics, depending on what type of patient you have, whether it's renal, whether they have problems, you'll choose a potassium wasting or a potassium sparing diuretic, something like that. The best way to measure preload, star, is Swan's cath. It is a part of hemodynamic monitoring. So the assessments. You know me, I like my acronyms. My assessment here is, my mnemonic study tips, is CASE, HEB, H-E-B. And what we're going to do is we're going to look at chest x-rays, we're going to assess arterial blood gases, we're going to assess serum electrolytes to see if there's shifts that are possibly being affected by our heart failure. We're going to do an echo. We obviously want to look at the heart, the chambers of the heart, the anatomy of the heart to see it's been affected, to see if there is any damage, particularly like the hypertrophies that we talked about in the left ventricles. Hemodynamic monitoring, we talk about PA, WP, and CVP. And basically those are all catheters that are going to measure arterial pressures and just pressures in the vessels themselves. Your normals for your PAPs are, here, I forgot a P here. I think that's pulse arterial pressure. Your PAP measurements are 15 to 25 millimeters per mercury, or 8 to 15. I'm assuming that's a male to female ratio. He really didn't specify in the PowerPoint. Then you have your PAWPs, which are CVPs. Your PAWPs are 4 to 12, and your CVPs are 0 to 8 millimeters of mercury. Okay? You're going to evaluate cardiac damage, and we all know that the cardioselective enzyme for cardio damage is troponin. So your normal level is 0.1. If there's significant damage, it'll be somewhere along the lines of 0.6. If there's very significant damage, it'll be up to 0.50, which is bananas. As you know, though, those cardiac troponins, they can be in your blood post-MI for up to, Margie, how many days?
I think it's 3 or 4.
3 to 4. They're in there for or 2 to 5, something like that. That might be ringing a bell. So even when somebody had a mild MI, let's say, and they decided not to get treatment, or they passed it by and thought, hey, I'm just having indigestion, despite having Levin's sign, fist to the chest and everything, in pain. I had to throw that out there just to make a reference to Levin's sign. You'll still be able to know if somebody had some type of cardiac complication because those enzymes will be present in the bloodstream. Then you have your BNPs. If your BNP is elevated, which is B-type natriuretic peptide, it's going to be indicative of heart failure to some extent.